the ground, hit the ground running. So when I see an MRI, these are the first few things that you want to observe. So right. So this is a 24-year-old female who presented, right-handed female who presented with seizures, generalized tonic-clonic, as far as I remember. So on MRI, there was this lesion. So the first thing that you want to look at is the T1 weighted image. So this is the T1 weighted image here. And sorry, I thought this was going to work for a pen. Okay. So this is the T1 weighted image here, right? And then this is the T1 with contrast, and then the T2, and then the flare, right? These are the basic images that we need. And if we have these images, which almost all the MRI machines do, whether they are 0.5 Tesla or 0.3 Tesla, we have enough information to proceed with our conclusion and decision making. Uh, so in here in AKU, when they do the flare, they do in coronal. In some places they do in axial, and they're all different. But if you do get coronal and sagittal, that also gives an idea of the extent of the lesion. So you want to look at, first of all, where is the location of this lesion? Is it intra-axial or extra-axial? So this is clearly intra-axial, and whether it is enhancing or not, and what kind of enhancement is there. So you see that it is a sort of ring enhancing. It's not very smooth, but it is pretty smooth though, except for this area over here. And then you look at the T2 weighted image, which gives you an idea about that the hyperintensity that we see in here. That hyperintensity suggests that maybe some kind of liquid in there, necrotic material maybe. And then you also see this edema around here. And of course, when you look at the flare, you can confirm that the liquid in there is not just free fluid, because the free fluid will be black. So the liquid over here is iso-intense or hyper-intense. So that means there's some proteinaceous material and things like that in there. And then you see the edema again over here. The other things that you want to notice, besides what part of the brain, and that depends on the anatomy that we talked about last time. Here you see that it's in the temporal lobe. Here you see the uncus is pushing over here. The brain stem is getting pushed on the side. You can notice this, the right peduncle is affected. And in this image that you can see over here, you can see that there's a significant mass effect on the ventricles also, although there is no midline shift so much over here. But then as you come down here, there seems to be a little midline shift over here. So these are the things that you want to notice and move forward, right? So this was a GBM, and I'll talk a little more about it later on. Now here is another image. I haven't shown a T1 with or without contrast, but here you see that this lesion actually was not enhancing. I don't have that image over here, but this lesion this is flare. Now remember, flare is just like T2, except for that the free fluids, they have been information has been processed that the free fluid appears black. So if you notice this, so you get used to this image right away when you look at this T1 weighted image में जो है, if you notice that the white matter is lighter than the gray matter, but then here the white matter is darker than the gray matter. So once you get used to it, it automatically gives you subconsciously कि भी ये flare है. So those who are new starting this, it takes some time, but then it becomes a subconscious. Suddenly आपको पता चलता है कि ये flare है. So these both are low grade gliomas, both of them are, and this is what we are trying to describe. That this is, and the reason recording is stopping, I don't know. Okay, so this is probably the precentral sulcus. इस सेक्शन में कहना मुश्किल है, लेकिन लग ये रहा है कि this is central sulcus over here, because this thing is thicker. I don't see a omega sign. यहाँ पे this looks like a little omega, but then this is too thin for that. So it's possible that maybe this is the central sulcus and this is the precentral sulcus. ये possible है. But see, this is the pars marginalis over here, so maybe this is the central sulcus over here. So kind of mushkil, one has to look at other images as well. So what it looks like from based on this image only, that it is in the left frontal, it's in the left frontal lobe, and probably in the close to the premotor area over here, and the motor cortex is one gyrus behind. Over here, it's further down below, but here it looks like that it is involving the lower end of the parietal lobe over here, with the edema or the tumor extending into the frontal lobe, and then the same image over here tells me that actually it is extending into the temporal lobe also, right? So look at all these information, and keep on assimilating the information to get an idea of where is the tumor extending, how much is it extending, what kind of effect it's producing, and all that thing. So there are some of the circumscribed and the infiltrative type of low-grade gliomas. You see over here, this suggests, I think, very clearly that the central sulcus will be somewhere over here probably. Well, we don't know exactly, maybe over here. And this extends mainly in the frontal lobe, because the central sulcus will be something over here. This is mainly in the frontal lobe here. This one right above the operculums, and in here, this is infiltrative, which is going on both sides and is crossing into the splenium as well. And over here is the right frontal lobe. Here is a diffuse extending into the parietal lobe also. You see this over here. Here it is extending along the corpus callosum, or maybe along the cingulate gyrus. So as much information as you can get. These are all these are all flare images. These are all flare images, right? And then you look at the enhancement. So once you have seen that it's intra-axial tumor, then you're thinking about main is a glioma, right? That's the first thing you're thinking about. But then keep in mind other things also which we'll talk about. So then you look at the enhancement pattern. Now, so low-grade gliomas typically don't enhance, right? That's what we know. But there are low-grade gliomas that can enhance. So here there are certain low-grade gliomas. If you notice this one over here, you see this enhancement over here. There's subtle enhancement that we see in here, right? And this tumor is pretty obvious on the flare image. So this is T1 plus contrast. This is T1. This is T1, and here again this subtle enhancement over here. So you can see that, and this is infiltrative type, diffuse margin. This is more circumscribed margin, but both of them are showing some kind of enhancement. And here the enhancement can be more definite. For example, in this picture, this is a tumor. Now, think about it in your own mind. Where is this tumor extending, right? So we talk about insular gliomas. So it is present in the insula, but then it's extending into the frontal lobe. It is extending into the temporal lobe, all the way behind. So it is an extensive insular glioma, and there is enhancement that we see in here, and this is definite enhancement, right? And then in some cases there can be intense enhancement. See this intense enhancement over here. This is a tumor that is actually causing subfalcine herniation over here, and it's diffuse. You see this one? This is subfalcine herniation, right? See the ACA, the branch of ACA. You can probably see the branch of ACA over here. That's going like this, and it's on both sides. And this is an infiltrative type. So what it tells us that the GBM typically enhances a lot, but but the the low-grade gliomas can enhance also, and it can be subtle enhancement, it can be a definite enhancement, it can be intense enhancement. But the chances of intense enhancement is less. So it looks like that those which are enhancing there's higher tendency that those be little higher grade compared to those that are not enhancing. So don't assume that low-grade gliomas don't enhance. There will be some low-grade gliomas which will enhance, and the enhancement pattern can be subtle to definite to intense. and just an enhancement does not mean that it is a GBM. वैसे आप लोगों को याद तो होगा that the classification of GBM has changed, right? So now we talk about all the IDH mutant cases as their astrocytomas as grade 2, 3, and 4 astrocytomas, right? And the numbers are now the numbers used are Arabic numerals. And those which are IDS negative, those are all GBM. Necrosis वाला उसमें जो है अच्छा अगर oligodendroglioma है, so we don't use the word anaplastic now in the new WHO classification. So जो oligodendroglioma है, that will be grade 2 and 3. And grade 1 is very circumscribed, little different, which always has been parasitic astrocytoma, different pathology. Okay, so moving on. Now in certain centers across the country, there will be facilities available for things like DTI, diffusion tensor imaging. Not in all places. It's not a necessity. If you have it, it's good, but then you have to have a good understanding of the anatomy. Yes, we all know that the arcuate fascicle is going to go like this. We all know that, right? And this is a tumor which if you look at the arcuate fasciculus, it disappears over here because of edema and all that thing. You can't see the those images. But this tumor is in the left frontal lobe, right? And it has little cystic nature. And I don't think it was enhancing. And on flare, we do see that these areas which are white in here, hyperintense, they are hypointense in here. That means it's very cystic. There's a free fluid in there. That's why it is like this. If it was calcium, it would have been black hair also, right? Because calcium would produce this kind of image, which you would see in oligodendroglioma. So this was a 36-year-old male who presented with dizziness and so okay, all right. And again, always keep in mind you have to look at the things where is it present, what kind of effect it's producing. It's causing a midline shift, mass effect, extent kitna hai. Because as a surgeon, you are always thinking about how am I going to take care of this tumor. So you're constantly assessing the tumor as you're looking at it. Yeah, so this is the same tumor which was removed surgically, awake craniotomy, and even if there was no DTI, this could have been a good resection because we were monitoring it. So DTI is not a necessity. Now here, think about it. This is a 63-year-old male with progressive decline. This is a contrast enhancing image, and this is all contrast enhancement over here. So it looks like a GBM, right? Now remember, GBM typically will cross the midline. Not typically. So those tumors which cross the midline, and the word used butterfly glioma, which is not used so frequently now. It typically are two kinds which cross the midline. One is GBM. Okay. The other one is oligodendroglioma, and usually high grade. And the third one is lymphoma. These are the three that cross the midline. Okay, so remember that. Now I wonder if the new classification, whether astrocytoma 4 should also be put in that. I don't know, because this classification just came out. Before that, we might have been causing that a GBM. Here is another image. This is with the DTI. Now DTI is, as I said, is not available in many places, but then over time, a lot of institutions are acquiring it. It's just a software with a 1.5 Tesla or 3 Tesla that gives you that ability. But in this case, it was a GBM. Even if I did not have this thing where it shows, yes, it is pushing onto the internal capsule and all that thing, you can still get an idea by looking at the images. And if you do a subcortical mapping, you can prevent this thing. And here it was a cross total resection of a GBM with intact neurology. But these DTIs help you. And I think at some point I'm going to talk about the diffusion weighted imaging also. Okay. So these are the images that I have acquired, or actually one of my resident has helped me acquire from Radiopedia, which is a very good source. And this is a diffuse astrocytoma. So notice that in this, sometimes you also notice these things. So this is T1. This is T1 with contrast, right? You do see that this is an enhancement over here, but then there's some, it's the difference in intensity across this, right? And that's the part that is enhancing more. And on a T2 weighted image, it looks like circumscribed. And on flare, again, not much edema around it. But then the main thing that you notice over here is what? That uncus is herniating significantly, pushing. The midline is getting pushed, right? The red nuclei are all getting pushed. This is oligodendroglioma. So in oligodendroglioma, this is a very intense picture of what is this? The CT scan, right? So this is all calcification over here. Now, usually don't see that much calcification, but in this case, we are seeing a pretty intense calcification. And this is again by Frank Gillard. That gentleman started Radiopedia. This is just such an interesting thing, and Radiopedia is like a big thing now. So whatever you guys start, lage raho, to cheezein aa jati hain. So keep that in mind. So this is all calcification. Now notice that when we go to the MRI, we do not see that calcification dropping signal so much. So don't expect कि जो है जैसे bone में आता है ना ये this thing. You don't see that in here, right? But then you do see some this, and when you get to the susceptibility weighted image, that's when you will see the signal drop out, significant drop out. So for example, over here, what we are seeing over here, right? But this is the lesion that is crossing the midline. Always keep in mind now, these two dots over here, they look like as if they are the two ACAs. I'm not 100% sure. I don't have other sections in it, but that's what it looks like. It is crossing the midline over here. It is, so remember I told you crossing midline, GBM, oligodendroglioma, lymphoma. So this is crossing the midline, pretty large, starting from the left frontal lobe. And यार मैं कोई गलती कर दूं ना अगर बोलने में, so please do tell me, remind me. मुंह से निकल जाता है कभी कभी. So there's a question about there was some chat पे कोई question था. Repeat the test. I don't know. Could you please repeat that test? Repeat what is this test? What is this test?
We'll take the question from the chat box in the end. What do you think?
Okay, sorry. So do we have this, and then we get into the diffusion weighted images. This is the ADC over here. So what does diffusion weighted image does? The molecules. So MRI depends mainly on the water molecules, right? The protons in it, as I told you in the first lecture. So in those areas where there's a lot of fluid, the water molecules are moving around like Brownian, based on the Brownian motion. So whenever they are excited in a certain phase, and then it's let go, as I showed you in the pictures, it gives the radio frequency signal, but in that time it might have moved somewhere else, and then excite again will do different thing, right? But if they are molecules are jakade हुए एक जगह पे, and you excite them, and then you change the angle of जो आपका जो magnetic जो field मिल रहा है, you do it exactly opposite, they will still be the same. So they will cancel each other out. And that's what is done, is what you see as dark, because there is no movement of that water molecule. So from initial B0 से लेकर आप B1000 तक चले जाएं, इसको enhance करते जाएं उसके effect को, वो effect नहीं आएगा क्योंकि वो water molecule जकड़े हुए हैं. They're not moving a whole lot. And that's where they show us black. But then in those places where the water molecules are moving around, they will, the difference between B0 and B1000 will be a lot. And that's where they will show us, for example, this free fluid, white nazar aayega. And then in something like this is like normal brain tissue. So you would expect in the diffusion weighted imaging that you would see sometimes a little more restriction in ADC में, dark shadows नजर आएंगे. And this is the cerebral blood flow, CBV or उसको relative जो है cerebral blood volume RCBV भी करते हैं. And there are different methods of it, अब तो it's just so many complexities, mind-boggling. So anyway, what it shows that the blood that is going into this region, whether it is little higher, taking higher blood, so it does look like that it is little higher blood flow in this region, and that suggests. So if it was, let's say, a dead tissue, then it will be much darker, like this. The ventricle में जैसे आ रहा है dark, है ना? Okay, so this is according to the data that I have from Radiopedia. It is a 60-year-old female with extensive flare abnormalities, crossing the corpus callosum and patchy contrast enhancement. You see this patchy contrast enhancement over here, and marked elevation of CBV, right? MR spectroscopy not shown, showed elevated choline peak. उसके बारे में बताते हैं थोड़ी देर में. So वगैरह ठीक है. Okay, so let's move on. Now this is a tumor. So notice these things in this tumor. On T1 weighted image, nothing specific. Yes, you see there's something over here. On T2, you see this like very hyper intense, very intensely enhancing, right? On T2, you see the same mass, but there's edema that's going around. and on ADC and diffusion weighted imaging, you see that it's maybe a little darker than the rest, maybe. Okay, here is another lymphoma, intensely enhancing on the surface. This is T1 with contrast. Look at this one, crossing the midline. You think splenium जैसे ना, splenium cross कर रहा है, right? So remember जो मैंने बताया थे तीन, right? GBM, oligodendroglioma, and lymphoma, right? So it's crossing the midline. It has to be lymphoma. Now, if it is intensely enhancing like this, it's a lymphoma. There will be some lymphomas, especially in immunocompromised, which will not be intensely enhancing like this. They will have sort of, an image of like what we have for the GBMs. Okay, I think I miss that? Just a second, guys. Where did that go? Did I miss that? Oh man, sorry. Okay, so moving on. This is a typical picture of glioblastoma, and T1 with contrast. Notice that the edges are irregular. It is you can call it ring enhancing, but it's very irregular. It's not a smooth ring like this, right? It's not. And then there's edema going around, and then on flare, there's a flare with contrast. Probably we are seeing some enhancement over here, but then the edema is going over here, and then some changes not related to this probably. Here, this is again from Radiopedia. So again, a tumor which is crossing the midline, butterfly. That's why it's called butterfly. Well, maybe it does look like a butterfly, right? Right, maybe. And it's crossing the midline. Again, this is the same patient. This patient is different. This is from a different source, where it is pretty solid. It's not like ring enhancing over here. So the things that we now use on top of these are MR spectroscopy. And MR spectroscopy, basically, there are different ways that the different molecules, just like water molecule behaves differently in magnetic fields, those bigger molecules will have a different, and with the NMR spectroscopy, you can pick up those signals specific for those. and it comes up in a graph like this. And typically, in the NMR spectroscopy, you will see that the choline of tumor, if this is a voxel, so you always get it in a very small voxel, uh, and a lot of time they would compare it with a voxel in a normal area also. So in that voxel, and remember, if this voxel is chosen somewhere over here, it will not give you good result. It has to be away from a lot of artifact producing areas. So in here, it shows high choline peak, and then there's creatinine, and there's NAA, N-acetyl-aminic acid. And this one suggests that there are more cells, but here the peak is not high. But this choline, turnover of the membrane, because membrane has a lot of choline phospholipids, that's what accumulates and that gives the high peak over here. So this is again showing the choline peak here, creatinine, and then NAA. And on the contralateral side, so here they did, okay, this is where they're comparing. See this one? This is the tumor. This is GBM crossing the midline, but not totally, which shows that the choline peak is high, this one. And on the other side, when they compare it with the other side, there's no choline peak. But then, the normal brain pattern shows over there. And based on those voxels, you can actually create images, but those images are very diffuse. So that's why people look over here in these graphs. Now, if there was a necrotic core of metastasis or GBM, then you will have a different thing. It's necrotic. So there will be no choline peak, no creatinine peak, but you will have lactate. And that's what you will see in abscess also. Lactate and lipids, you will see those peaks in here. Now, in the low-grade gliomas, there's not much of multiplication of cells, not much turnover, but there's a lot of cells in there, right? Typically, like oligos and all those. And that's why you have a high NAA peak, but not so high choline and creatinine peak. So if the choline peak is like this, and then creatinine peak, and then NAA, this, if you draw a line like this, then that is for high-grade glioma usually. Something like this is for low-grade glioma. Acha. So what time is it? It's 8:34. I think we are done.